GUIDE is a healthcare service delivery model that offers coordinated and comprehensive dementia care, including training and supports for unpaid family caregivers. Its goal is to improve the quality of life for persons diagnosed and care partners alike. Joining us today to talk about GUIDE are Dr. Halima Amjad of Johns Hopkins University and AFTD's Board of Directors, Dr. Eric Anderson of Synapticure, an organization that coordinates virtual care for people with neurodegenerative disease, Dr. Hilary Lum and Adreanne, Tatro, I think I got that right. And they'll be joined by my AFTD colleague, Sharon Denny. Please give them a round of applause.
Thank you, thank you.
Yeah.
Thank you, Esther. So we're excited to share some information with you today about GUIDE, which is a really important development in dementia care. As you know very well, many people getting a diagnosis today of FTD are given a little bit of information. They're left on their own to find services, find supports, find resources, do all the coordination, do all the advocacy. You're kind of left on your own to do it all. We know that it's also really frustrating when you look around and you feel like there's not a lot of progress being made that you can see in terms of this process changing, this reality changing. So what we want to do today is to talk to you about the fact that there are changes coming. There it is, thanks. So GUIDE is the first comprehensive dementia care model covered by Medicare. Over the past 20 years, dementia researchers have been studying what services and what supports are most effective for helping you. Based on this important work that's been collected over time, they've culled the best elements of what dementia care should really look like, and that's what's being combined into GUIDE. GUIDE was launched in July of 2024 as an 8-year pilot program that's evaluating whether this national model of comprehensive dementia care can improve outcomes, reduce hospitalization, and help to limit costs so that people can get the care that they need. As it rolls out, it's going to include 371 providers already approved across the country. It will include academic medical centers, home health care companies, telehealth providers, and an array of community services and supports. And we also know there's a lot in the news these days around changes at the Department of Health and Human Services at the federal level. It's our confident understanding that CMS remains committed to GUIDE and that it's going to continue to roll out the way it's been expected to. So GUIDE is not specific to FTD. It's designed for people with any form of dementia, but includes FTD. GUIDE defines quality care as being person-centered, coordinated, and comprehensive. So exactly the opposite of what your reality is right now. It structures services based on an assessment of individual needs and considers a wide array of services and supports to help you. The approach requires the availability of these 8 elements that you see on the slide. All programs need to have these elements available to any people participating in a GUIDE program. And we'll talk about these elements in a minute with our panel. But it's important to realize that this is the first time that Medicare recognizes and will reimburse providers for services that we know you've been hungry for a long time. So it's going to include things like help to identify and find resources and help to connect you with them, access to a care team 24/7 for those questions that aren't conveniently done during business hours, and respite for individuals, for caregivers who are eligible, so that you have a chance to take a break and hopefully extend the time that care can be provided in the home. The model also recognizes, importantly, that caregivers are doing an awful lot of on-the-job learning. And so the assessment will include an understanding of your needs and make sure that you have access to training and support to help you build confidence in this new and challenging role. And then a hallmark of Guide is that it empowers the care navigator on every team to be a partner with you to help to coordinate the care that you need. So just quickly, who might be eligible for Guide? People will be eligible for Guide if they have a dementia diagnosis, again, any type, if they have Medicare Parts A and B as their primary health insurance, if they live in the community or assisted living, but not in a nursing home, and if you're not enrolled in hospice or a PACE or a Medicare Advantage program. So for today, we'd like to ask you to think about Guide as a framework for care. It's implemented across different types of providers, all across the country, city, suburban, rural. Lots of variety is going to be what will be represented in how these programs are developed. The required elements are the same in every program, but each one's going to look a little bit different. And they're all going to be rolled out over time in a large initiative that's going to have some startup time required. So now we're going to switch, oops, don't look at that yet. We're going to switch to talk to our panel and dig into these ideas a little bit more. So let's start with, how do you get connected with a Guide program? And I'd like to ask you, Dr. Lum, to tell us a little bit about this. So Dr. Lum has worked at the University of Colorado providing comprehensive dementia care for many years and has some experience that she can share with how we connect people to Guide based on that.
Well, it's really a privilege to be here to talk about launching a Guide program. We started in August at the University of Colorado. Referrals can come from the community. You can self-refer to a Guide program. Another common way is that a clinician who you may be seeing related to your FTD diagnosis may be aware of the Guide programs available in your area, and they may, on your behalf, contact the Guide program. We will then look at the eligibility that Sharon outlined, and we'll begin the enrollment process.
Thanks very much. So can you tell us a little bit about, when somebody is enrolled, what does the assessment start to look like?
Because you saw that the program overall has many components, which we'll be talking about today, the assessment does take time. I would say there are probably 3 steps that are common across Guide programs. You'll be outreached to schedule, and that may involve some initial screening questions. Then you'll have a visit, we call it a Guide alignment visit, with a dementia specialist. The purpose of that visit is to confirm the type of dementia, the stage, to ask some questions about a caregiver, if a family caregiver is involved. And then we submit that information to Medicare. They let us know after 15 days that the person is approved. And then the third part is to be contacted by the designated care navigator to start the ongoing outreach, which will typically be monthly, though may also be every 3 months, depending on the stage or tier of the person.
So it sounds like it's important to appreciate that there's a little bit of startup time involved in the process of the enrollment and the assessment, and that should be expected in any of the Guide programs. Thanks very much. So Dr. Anderson, you're the Chief Medical Officer at Synapticure. Synapticure is an innovative telehealth model of delivering dementia care, having started in ALS, done some work in FTD and other disorders. So you're also providing guide services now from within the Synapticure model. I wonder if you could tell us a little bit about what you found as key takeaways from the assessment process for folks with FTD that have come through Synapticure.
Yeah, thanks for that. So I think just to kind of give a little bit of an overview of what we do, for those of you who are not familiar with Synapticure, we started in ALS. It was founded by a patient and a caregiver, and our model has always been based around that experience. We have incorporated care coordination from the get-go, and so we were an easy fit into the guide model, given that it's probably the first federal funded program that recognizes caregiver support, which I think has been a long time coming. To Dr. Lum's point earlier regarding the assessment of coming into the program, there are faster mechanisms for people who have already gone through this lengthy diagnostic odyssey, as we call it. There is a provision where if another Medicare-associated healthcare professional has rendered a diagnosis of dementia, we can accept that and we don't have to reinvent the wheel. So if you're coming in and you've already gone through that lengthy struggle of getting a diagnosis, you don't have to do that again. There is a staging component, which is, I think, relatively brief, but that's just for classification in the program. We accept all of your existing medical records and experience and can enroll you into the program with an existing diagnosis of FTD.
Thank you, appreciate it. And that's important for folks because we do hear that having to do all those tests is not something you relish the idea of doing again. So Dr. Amjad, you're a geriatrician and a dementia researcher who's worked at Johns Hopkins and has worked with the Mind at Home model for many years. Mind at Home is one of the models that's informed guide. And so people may also know, some of the people in the room today may know that you also have experience with FTD in your family and have shared that with us before. I wonder if you could tell us a little bit about what aspects of guide you think would be of the greatest potential for people with FTD.
Yeah, I think big picture, all of it, that guide really can provide a lot of the support that we're all looking for, but we know the medical care system doesn't provide it, and insurance doesn't currently pay for it. I think the care navigator is really key. It's someone you can talk to regularly, right, in what we know is an isolating journey. And those contacts really fill those long gaps between specialist appointments. I think in terms of other aspects of guide that are helpful, FTD families, right, are often figuring things out on their own. So having that assessment and care plan can really help you get grounded, organized, and get started. And as Sharon mentioned, all of these elements should be personalized to your needs and priorities, where it's really important to be open and honest about what you're experiencing and what you're going through. We all know too that FTD caregiving, really it's like two full-time jobs, right? There's the hands-on care, but then in the slide Katie shared earlier, right, there's all those additional coordination of care and advocacy tasks. And the guide program, as well as that care navigator, can really help with those care coordination and advocacy tasks. And the respite care payment can help a little bit with the hands-on care. I also know in our community there's always questions about medications, right? Is this medication regimen right for my loved one? And guide is really supposed to focus on the medications and the person. And then I think the home visits are really important, right? It allows the team, the care navigator, to really understand the person, the family, and the situation. And right, we're already talking about caregivers. I think that's the other big piece of the program, is that Medicare is paying attention to the caregiver. There's requirements for education and support. They're measuring caregiver outcomes over time. That education, right, some of it's not gonna be, most of it's not gonna be FTD focused, but I think our community can still benefit from that general education and support. And so big picture, I'm excited about the guide program and what it can start to provide for the FTD community.
Dr. Amjad, I want to just ask a follow-up question because we hear a lot from the community that folks end up working with providers who don't know what FTD is, and they end up needing to educate the providers. So as people approach guide providers, what should they expect in terms of how much the folks will know about FTD?
Yeah. So likely there still will be a role for our community educating the guide teams, right? Like most things in dementia, a lot of the programs and care models are going to be coming from the Alzheimer's world, and programs will differ in, right, do they have FTD expertise on their team or access to experts? But that's where, one, if you have an option of multiple programs, you can ask directly, right, do they have FTD experts on their team or access to it? And all care navigators are required to have some base training in dementia. So they will understand that there are different types of dementias. And while they might not be experts in FTD, right, most of the people who are filling these roles are open and interested in learning more, where you can encourage the care navigator and the team to get educated on FTD. You can refer them to the AFTD and to other learning resources. I think ideally for the FTD community and for families, what will be ideal is combining the guide resources still with some FTD-specific resources, right, many of which that are available through the AFTD.
Thank you. And we're very fortunate today to have a care navigator with us. So Adreanne Tatro is with the University of Colorado and has been working as a care navigator for a number of years within the model they have, and is now in that role for guide. And I wonder, can you just describe a little bit more about what people could expect from this really important part of the model?
Absolutely. So as a care navigator, it is a privilege that we get to focus on the relationship aspect. So building a relationship with the families, being able to be a listening ear of what's going on in the home. We get to do that because we are speaking with families on a monthly basis. So it's not waiting until the next provider visit. You have that monthly touch base of how have things gone in the last month? What has been going well? What has been challenging? Anything new that has popped up? Another big aspect of our role is to be able to personalize any resources and education. So you may be provided with a great resource or handout or whatever it may be, but what does that practically look like in your home? With your personality, your family situation. Your care navigator would then be able to ask follow-up questions. How did that go? Do we need to adjust something or start from scratch, like that resource or that strategy is not working? Let's rethink that. We're also able then to learn about the situation or a challenge that might be popping up, and then be able to coordinate back with whoever your provider is, whether that's a neurologist or primary care provider that you're working with. And so we're able to provide that bridge back to the healthcare team. As was mentioned, your care navigator is not necessarily going to be the expert, but we are a team-based program, and so we are surrounded by experts. So we're able to take those questions. I tell my families a good example is medications. You don't want me messing with your meds, but I can take that information and I can put you in touch with your provider or with a pharmacist that can give you a call and answer your questions right away.
Thank you. And Dr. Anderson, I know that people are going to be curious about what's the difference between a virtual telehealth model and a more university academic center-based model. So, and there are multiple virtual models out, companies doing virtual telehealth and guide. So can you talk a little bit about what might be the same or what might be different?
Yeah, so that's a great question, and thank you for that. I guess what I would say is that the mission behind the build for what I put together for Synapticure is that we wanted to bring center of excellence care to people no matter where they were. We firmly believe that the quality of care should not be dictated by someone's geography or their ability to travel. And so a virtual model initially targeted towards ALS patients or people living with ALS and their caregivers led us to the natural evolution into FTD care and then movement disorders and now a full-blown cognitive program. And so what I would say is that the difference between a virtual model and one that you have in person is that the virtual model does allow some benefits to people and caregivers that they otherwise wouldn't have when they're in a traditional setting. For example, we have several caregivers who tell us that they were unable to travel to clinic or that their loved one's behavior prevented them from driving to the clinic because they tried to get out of the car while they were on their way there, that they feel that the best way that their loved one can be evaluated is in their home as opposed to in a clinic. And it saves a lot of time for people, and it allows us to bring all of these hard-to-find resources that otherwise are inaccessible to people and bring them to them in their home. So for example, we have like Brooke yesterday was speaking on genetics. We have genetic counseling. We bring an entire full stack behavioral and mental health program with geriatric psychiatry, neuropsychologists, therapists, behavioral health care managers. We have subspecialist neurologists in movement disorders, neuromuscular disorders, and cognitive disorders. And along with insurance navigation and of course care coordination, which ties all of that together, I think is exceptionally important. And again, thankful that the GUIDE program is recognizing that. But that being said, there are still in-person requirements that are necessary. And so some of those things include respite care. So in order to do this in all 50 states, we have partnered with 200 different respite providers, right? And the majority of them provide in-home respite, and there's a handful that provide inpatient respite. We also had to work with a lot of other groups to provide in-person, like physical therapy, occupational therapy, as well as home assessments, which is required for some people who are more advanced. And so ours is more of a hybrid model, and we've launched this with on-the-ground personnel in certain high density regions, but we continued to build that out, and I hope that answers the question.
It does,
I kind of went into a lot of detail.
Yeah, I appreciate that, and I appreciate you mentioning respite because we have said that respite is an important service. Dr. Lum, I'm actually going to ask you a quick follow-up because how does respite look different for your clinic? How do you approach respite?
As we think about whether you have a GUIDE program in your vicinity, Medicare has a national list where you can see participants in your area. So that's a place to start to find a program. Then once you're contacting a program, like one of the 6 programs located in Colorado, some of the intake will involve asking what your zip code is. Part of that zip code question is identifying whether the GUIDE program, our GUIDE program as an example, has the arrangements and partnerships to be able to do the in-home assessment as well as the respite care. In most GUIDE programs at this point, in our first year as we're getting started, respite is going to typically look like in-home care provision. Some programs may have partnerships with adult day centers, and some programs may also have respite partnerships in a skilled nursing facility center. So I think it's going to vary. Ours currently looks like in-home care, and I think that's pretty common. The role of the care navigator is to walk you through what respite is available through GUIDE. It's also the GUIDE navigator's goal to understand other options for respite, such as through AFTD or local through perhaps the Area Agency on Aging in the location that you live.
Thank you, and thank you for that plug because you saved me. But for folks who don't know, AFTD does have the Comstock Respite Grant Program, which has a companion quality of life care program. So go to our website and look them up as a resource if you're not familiar. So I'm going to come back to you, Dr. Lum, with another question, because we have said all along that one of the requirements for GUIDE is to have Medicare Part A and B. And that means that not everyone's going to be eligible. So are there suggestions that you have for people who don't right now have Medicare?
I think that still reaching out to a GUIDE program is something that you can now add to the outreach that you're all doing. As you're thinking about how to coordinate care, please do reach out to a GUIDE program in your area, because we are seeking to be a hub that we might still offer recommendations of services that we're aware of in the local area. We also then are exploring, GUIDE programs may be exploring how to leverage other reimbursement opportunities that Medicare is making available to healthcare teams. There are new caregiver training codes that are available. There are also codes called principal illness navigation. So even though GUIDE may not be specifically available to you, please reach out to your care team to find out what they may have available. Keep asking. As you ask, that reminds us of the need, helps us to know specifically where the gaps are, and we really seek to build better connections.
Thank you. I also want to add that we know that it's a difficult decision. It's a complicated decision to select your healthcare insurance provider. And just by way of reminder that every year there is an enrollment period. And so that's a good time to take a step back and maybe talk with folks to see, is the insurance doing what you need it to do? Because there are options. And for guidance around making those decisions, you can turn to the state health insurance program in your state. And you can also call our helpline and folks can point you to resources from there. There we go. So unfortunately, we only had time to kind of introduce you to some of these aspects of GUIDE, but I really appreciate the expertise of our colleagues here because it is something we wanted to make sure that you're aware of. It's an important development that's evolved out of two things that we've talked about during the whole conference: research and advocacy. And AFTD is following this model because you know that what we do is we advocate on your behalf to make sure that as the field of dementia care moves forward, there's a loud voice reminding everyone that your particular needs and the needs of people with younger onset dementia need to be included in these models. But we can't do it without you. So I would ask you that if you are reaching out to GUIDE models, if you're already participating in a GUIDE program, please help us to understand more about your experience and to get feedback from you, because we will fold that into what we're doing to try to make sure that education about FTD is available to all of these providers and bring that information forward to kind of pick up on what some of Dr. Amjad was saying. And we're also looking to make sure that if we need to be advocating with CMS to expand the model, or as it gets, as there's more experience with it, we're going to be doing that too. And so the more that we can have your participation and help as we do this work, the more that we can make sure that moving forward, dementia care models are designed to meet the needs that you all have. Thank you very much. And I want to really thank our panel.